Yeah, good afternoon, Bonnie. Good afternoon. So, Dr. So, can see Naid. Yes. Okay. Dr. Lamode. Yeah, I can see everybody. Nice having all of you online. And nice to see you again. So, we'll go straight. We'll start the webinar. So, welcome all of you to today's edition of Get COVID-19 webinar series. So, just treatment consortium gets to this, especially in Africa. Set up in 2015 at the peak of the Ebola crisis that ravaged some countries in West Africa. It was clear during the crisis that African countries lacked the capacity to cope with health emergencies like this. And there was an urgent need to set up organizations then to build capacity of both government and non-governmental organizations to cope with health emergencies and emerging infectious diseases. And GET was one of the organizations that was set up in 2015. And since 2015, we've been working with both government and non-governmental organizations in Africa to build their capacity to manage infectious diseases, such as the Ebola crisis and the COVID-19 pandemic that we are having today. And this webinar series is one of our activities to discuss issues around COVID-19. And today we have 4 great minds that will be discussing issues with us. And we'll be talking today on global biosecurity threats, lessons from COVID-19. You agree with me that though we are not sure of the source of COVID-19, whether it's from a market in Wuhan or from a laboratory in Wuhan, but one thing is clear that human activities over the years, whether in the lab, where we are not taking the necessary precautions we're supposed to take, all in our environment where we continue to destroy the environment, which is leading to increased contact between human beings and animals and leading to increase in occurrence of disease, where we continue to pack different species of animals together and there's constant transmission of microorganisms between different species of animal. All these activities is leading to continuous increase in biosecurity threats all over the world. And in recent years, we have seen increase in emerging infectious diseases and zoonotic diseases at the rates and level that we never saw in the history of mankind. And these are challenges that we're facing. And the big question is it's now clear that an issue that started in China within a few months can get to almost all the countries in the world. And no countries an exception, and no countries left out of these biosecurity threats that's affecting the whole world. Human race learns anything from this COVID-19 and this biosecurity threat that we're facing. The second one is, what are we going to do to prevent future occurrence of global threats or global pandemic that we're facing now? These are 2 big questions, and we have great minds that will be trying to answer some of these questions today. Today, we have 4 speakers that will be speaking with us. We have Ambassador Bonnie Jenkins, we have Dr. Abdurrahman So, we have Dr. Naid Badelia, and Dr. Mohamed Lamode. So the meeting will go like this. I will give a short bio of each of the speakers, and the speaker will have each speaker will have about 10 to 15 minutes to make a presentation. After their presentation, you have opportunities for question and answer. But if you have any question, what you can do is to type the question in the chat corner, and we are going to take your questions after the presentations. And please, if you're not speaking, make sure you mute your system. So we'll go straight to the first speaker of the day, which is Ambassador Bonnie Jenkins. I will read Bonnie Jenkins' bio, then I'll hand over the floor to her immediately. So Ambassador Bonnie Jenkins served as ambassador at the U.S. Department of State from 2009 to 2017 as coordinator for threat reduction program in the Bureau of International Security and Non-Proliferation. She is a U.S. representative to the G7 Global Partnership Against the Spread of Weapons and Materials of Mass Destruction, and chaired the Global Partnership in 2012. She was the Department of State's lead on the Nuclear Security Summit, and she coordinated the Department of State activities related to the effort to secure all vulnerable nuclear materials. Both Ambassador Jenkins have dedicated significant attention to the engagement of Africa in the threat of chemical, biological, radiological, and nuclear weapons. I'm working closely with the Defense Threat Reduction Agency, has developed a program, threat reduction in Africa, to help ensure that U.S. programs and activities secure in CBRN security are well coordinated and as accurately as possible meet the need of countries where those programs are engaged. She currently runs an NGO in US, and hopefully she'll tell us a bit about it. So I'll hand over the floor to Bonnie Jenkins, and she has 15 minutes to give her presentation. Bonnie, please, you have the floor.
Great, thank you so much. It's really a pleasure to be here to do this virtually. I was able to be part of some of the GET events in the past. And so it's great to be able to be with you here. We have some great speakers today talking about biosecurity and issues related to that in COVID-19. So I'm just going to give a bit of a background on something that I worked on called the Global Health Security Agenda, and also an opportunity to say a little bit about, how important that work is now. The Global Health Security Agenda, or GHSA as it's called, was established early in early 2014. It was really because we recognized in the US in 2013, actually, we had some meetings, interagency meetings, and I was in the government, as you heard, working at the Department of State. And one of my areas of focus is biosecurity, in addition to chemical and nuclear security issues. And there was a whole of government gathering of about 2 individuals from a number of departments and agencies in the government. And we were asking ourselves a question about what should we do about the fact that we're seeing this increase in infectious diseases around the world. And we're also seeing an increase in the amount of money that's being spent to prevent, detect, and respond to these diseases. We were looking at SARS, which had been about $3 billion in 4 months. We saw the anthrax attacks in the US that infected 22 people and cost more than $1 billion to clean up. The H1N1 in 2009 killed 2,084 people, and in the first year alone. We knew that AIDS had been spreading for years, and we had a rise in antimicrobial resistance issues, which is the resistance of our bodies to antibiotics. We realized more needed to be done to try to deal with this issue, and we also knew that a number of countries were not going to be compliant with the WHO international health regulations at that time, which are international regulations, as you know, that signify that a country has the capacity to be able to address a global disease threat or a threat within their region or country. So we recognized we needed to do something, and we needed to work closely with international organizations, including the World Health Organization, the Organization for Animal Health, and the the Food and Agriculture Organization, but also entities like the World Bank. And so we also realized that we needed to work with the non-governmental sector because so much work on infectious disease takes place outside the government with NGOs, think tank, academic institutions, philanthropy, private sector. So we realized we needed a whole of government approach and also a whole of society approach to deal with infectious disease issues. So we launched the Global Health Security Agenda in February 2014, which I'm sure many of you know about that. And then we had Ebola that hit really the world's knowledge about it in March. So 1 month later after that, which really provided a lot of impetus for the work that we were about to do in GHSA, which now has 69 countries who are a part of it. From the very beginning, we realized the importance of biosecurity in this issue of global health issues and concerns. As I said, I worked on biosecurity for a number of years, and so I was brought into these discussions initially in 2013 to bring in the biosecurity discussions related to global health and infectious disease, along with a couple of other colleagues. And we highlighted, the work that we had been doing starting back in 2011. In the US, we started to integrate biosecurity with infectious disease. We started to make those statements at entities like the Biological Weapons Convention meetings. I chaired something called the Global Partnership that focused on issues of weapons of mass destruction, but here as well on the biosecurity side, I started to integrate into our meetings representatives from the World Health Organization, Organization for Animal Health, Food and Agriculture Organization, and also entities within the US like the Center for Disease Control, Health and Human Services, Department of Agriculture, other entities into our discussions because we realized that we needed to look at these issues of infectious disease in the biosecurity space, but also alternatively in the infectious disease space to bring in biosecurity. And we realized that, a lot of the entities that deal with infectious disease outbreaks are the same entities, regardless of how it started. And that this issue is a national security issue. And we thought about the work that RAND had done back in 2006, which talked about the increasingly recognition that infectious disease can have a significant effect on world security, and that we needed to be protected from these go across the globe so quickly really do have national security impact. So, so there was a recognition early on the biosecurity needs and relation to infectious disease. And this was reflected in the adopted Global Health Security Agenda work in the fact that we have a number of what we call action packages in the Global Health Security Agenda that the 69 countries work on. And the biosecurity, biosafety is one of those action packages and is actually one of the stronger action packages in terms of the work that organizations are doing and countries are doing on that space. One of the really good things about the Global Health Security Agenda is that, as I said, we have 69 countries who are a part of it working on different aspects of infectious disease to prevent, detect, and respond to infectious disease threats, which is a foundation of the GHSA. And it's an entity that is working multisectorally, as I said, with different organizations, different non-governmental organizations, different departments and agencies within countries working together. We do have the World Bank, the African Union, the ECOWAS, the EU, to name a few entities that are a part of it, as well as the main international organizations, WHO, FAO, and OIE that I mentioned already. And working with the non-governmental sector. So it's an entity that's working on a number of issues related to infectious disease. Biosecurity is just one of those entities, those areas that they're working on. Some of the other action packages include zoonotic disease, workforce development, surveillance, laboratory systems, immunization, and antimicrobial resistance. And so these are different action packages that countries are working on together to try to increase capacity amongst all countries to prevent, detect, and respond to infectious disease. So looking forward, as we go forward into the future, we need to continue to work with the GHSA, the 69 countries who are part of it, all the different entities that I mentioned, governmental, multilateral entities that are working with countries on this effort. It's not getting a lot of attention in COVID-19. You're not hearing a lot about GHSA, but it is out there. It still exists. It's a great forum for countries to work together on many aspects of infectious disease, including the biosecurity and biosafety work that's going on. That is so much. There were allegations about how COVID-19 started. I think it's very important, and I think our other panelists will talk about the importance of biosecurity, the importance of making sure that our laboratories are safe and secure, that we can continue that work around the globe, and that countries continue to input money and resources into the biosecurity work to ensure that there is no intentional aspects to infectious disease. I guess I'll just conclude, as I see my 15 minutes coming up quickly, is just to say again that there are many aspects to the GHSA. You can go online on GHSA agenda and learn more about GHSA and the things we're doing in biosafety and biosecurity, in addition to other things that the governments are working on together. There is something called the Joint External Evaluations that are now being run by the World Health Organization, where experts go to a country for about a week or so and do an assessment of how a country is prepared and their capacity for dealing with infectious disease. Those have been invaluable. Some of those are on the website if you want to see those. That leads to plans that countries work on with international organizations and foundations on how they're going to improve their security, their capacity for infectious disease, prevent, detect, and respond in a five-year plan. The GHSA has a steering committee that meets several times a year. There's a ministerial of ministers that meet as well once a year. So there's a lot going on in terms of having an infrastructure and a foundation for dealing with infectious disease. So even though, like I said, you're not hearing about GHSA and what they're doing, they're out there, they're doing the work. I think it should be built upon. In light of COVID-19, build on what's already been established through the GHSA on infectious disease and prevent, detect, and respond, but also in line with what we're talking about, strengthen the work that's being done on biosafety and biosecurity within all these countries and amongst all these countries and international organizations to make sure that we can prevent any potential deliberate use or accidental use or results that can lead to infectious disease and epidemics and pandemics. So I think I'll leave it at that and turn it back to our hosts. And thanks again for inviting me. And I look forward to hearing what the other experts have to say. Thank you.
Thank you both for a wonderful presentation on GHSA. I heard about hearing about GHSA. Hello, can you hear me?
Yes, we can hear you, sir.
Yeah,
hello, can you hear me?
Yes, we can hear you.
Okay, great. Yeah, thank you for the presentation on GHSA. Right from the, okay, yeah. I started hearing about GHSA during the Ebola crisis, and they've been doing a great work since then. And I'm sure, I know the United States of America played a very pivotal role in starting the GHSA and in funding, but I'm not sure what exactly. And I don't know how well we need to galvanize an objective, especially with the increasing incidence of emerging infectious diseases all over the world. So that was a great presentation from Bonnie. Then we'll go straight to the next presenter. The next presenter is Dr. Abdurrahman. So I'll read the bio of Dr. So for 2 minutes, and I'll hand over to him to give his presentation. Medical epidemiologist and head of laboratory services in charge of epidemic control and public health West African Health Organization, WAHO. He has more than 15 years experience both at national and international levels in management of public health programs and emergency situations, emerging and re-emerging diseases, surveillance, and epidemic-prone diseases and infectious diseases boldly. I want to say Dr. So is one of the heroes of the Ebola epidemic we had in West Africa, and is still one of those in the front line against COVID-19. He has been doing a great work on West African sub-region on emerging infectious diseases, and is one of the people I know we should celebrate on this continent, considering the huge effort he has been putting in to trying to make sure that we curtail epidemic and pandemics within the region. Thank you, Dr. So, for a great work you're doing. We sincerely appreciate what you're doing in that sphere, especially in West Africa. So I'll hand over to you. You have the floor and you have 15 minutes to speak. Dr. Flo, Dr. So you have the floor, please.
Yes, thank you. Thank you very much, Mr. Chair. Thank you for giving me the floor. Thank you also to invite me in for this important meeting. It is really my pleasure to be here today to share some of our experience we are having now in West Africa. Let me greet you. Today is our anniversary of our 33rd year of WAHO. For today, we are focused on the bridging the gap to health access and health and security, because now, as you say, we are in a very difficult time during this COVID-19 epidemic. So my talk will focus on the COVID-19 situation in West Africa and what have been done from Ebola to COVID-19, and what was the responses to COVID-19 pandemic at the WAHO side, and so which are our challenges and lessons learned. So as yesterday, in West Africa, we recorded 88,000 new cases, and also about 1,473 deaths. As you can see here, this is representing 13% of all the African cases, also 20% of the deaths in Africa, because as you know, Southern Africa and Northern Africa are the highest burden in the African region. So in our region, Cabo Verde is the highest country affected by COVID-19, because we can use, as you can see here, we have 54% per 100,000 population, followed by Ghana, Cote d'Ivoire, Guinea-Bissau, and Senegal. We can see also for Gambia, we still have some sporadic cases. Also in Burkina Faso and Niger, the epidemic seems to be at the end because since several times now, we have just very few cases after the peak. So in terms of deaths, Niger and Burkina Faso has the highest case fatality rates in the region, with respectively for Niger like 68 deaths and Burkina Faso 53 deaths. So you can see in our region, our hotspots now in the region are Lagos, are Abidjan, Accra, Conakry, Dakar, and also Guinea-Bissau, where we can have also the highest burden of the population in terms of density. So in terms of the population impacted, we can say we can see in our region now a predominance of male adults in terms of confirmed cases, and also we can see young people and elderly are not well affected, even though we know in terms of deaths, the elderly people are the most affected. So what has been done from Ebola to now, and of some lesson we learned from Ebola was we had insufficient diagnostic capacities, weak national, regional response capacities, and also an absence of collaboration between the countries. So this led to our head of states to decide to establish the ECOWAS Regional Center for Surveillance and Disease Control in Abuja. And for each country, they established a national coordination institute with four core components, which are laboratories, surveillance, investigation, and training and research. And all the activities are being coordinated in the country by the NCI, following the One Health approach. At the regional level, we have established many bodies as the West African Network on Infectious Diseases, which are the very strong one, which can do the networking with all the NCIs, and they are sharing data, sharing experience between them. And so we have also established the West African Reference Network, and also the ECOWAS Rapid Response Team, for which we are very proud, because we were able to deploy some people in the countries where we had some epidemic these last years. For the West African Regional Lab Network, this includes all the national reference laboratories we are having in the region, and also we have established some regional reference one, and they are working closely with WAHO, with Africa CDC, and also all the at national level they are coordinated by the NCI. The objective of this network is to support ECOWAS countries to work together to enhance the biological diagnostic and also to strengthen surveillance capacity. We identify our gaps and limitations before to operationalize this center at regional level and also at national level. You can see here for the core capacity needed to prevent or to fight diseases, which are prevention, detection, and response. We had in many countries, the level was red because this has been done through the GE evaluation in the countries. From there, now we develop our strategic plan for laboratories. For example, here you can see we have four pillars. The first one is we need to strengthen the public health laboratory network. We work to develop regional policy and guidelines, establish laboratory information and management system, and also do the promotion and research and development through the emerging diseases, establishment of a regional biobank, and also working on antimicrobial resistance. So we have been able to have some results so far. We have already developed our regional plan for epidemic prevention and response, which has been activated now when COVID-19 happened. And also we support all our country members to develop their own, and we support them also to start to for their implementation. We have also, as I said before, this regional rapid response team now functional. The experts have been deployed in several areas in our region. Last year, they have been deployed in Nigeria during Lassa fever in Liberia and other many countries to support the countries. We established also the networks, as I said before, on laboratories and also in these surveillance, where people can share experience and data and so on. And also we have established the regional biobank in Abidjan, where we can collaborate in research and also promote research. Also, one of our big results also, we have developed the regional biosecurity and biobanking plan. And we are also proud to see here all the seniors in our region. We are working with them. You can see in the pictures, Professor Mireidoso, Professor Abraham, Professor Omilabo, and also Professor Akin Abayomi was working with us in this project. So we can see now from Ebola to now, the region has been very strong now because we put in place many bodies and many structures which can help us to fight the epidemic. So now, once we have the COVID-19 pandemic, how WAHO has responded to it. The first thing we did in February, before any case in our region, we organized a meeting in Bamako with all the health ministers to harmonize all the strategies in terms of preparation and response. And later in April, our head of states had a summit where they appointed His Excellency President Mohamed Buhari as a COVID-19 champion to answer high-level coordination in the region. So from there, they established many other committees for the implementation of the recommendation we got from the president. So these are some recommendations we got from them, and WAHO has been tasked to coordinate the COVID-19 response in the region, support the countries also to establish and to implement their strategy, for example, the strategy for testing, tracing, and treating all the cases. So in this regard, WAHO has been able to do some coordination activity and also some technical assistance activities in the region. For example, we have at weekly basis a meeting with all the NCI and the managers of labs, and also with our partners. We have also monthly meeting where we give them the feedback and also take some recommendation. We are able also to provide to all our country members with diagnostic kit, PPE, VTM, and all those things. And also now we are working to provide them by rapid diagnostic tests that have been already tested and validated. So now we are in the process to deploy it in all our region. We have also provide some financial support to our country members in terms of to allow them to deploy some experts to do the contact tracing and also some training. These are some pictures where we provide some goods in the region. So we have also organized some online training at regional level. We were able up to now to train up to 2,000 health workers in different areas, such as prevention and control, risk communication, contact tracing, and so on. So in terms of testing, now we have testing more than in the region. We have testing more than 700,000 tests, and the positivity rate now is about 10%. But we have only tests more than 1% of our population. This means we need to improve our testing capacity in the region. It's what we are doing, because as you can see in this slide, at the beginning in February, we had only 2 laboratories having the capacity to diagnose, one in Accra and another one in Dakar. For now, we have more than 100 laboratories able to diagnostic, and we are working with the countries to expand the laboratory capacity in the region. In terms of response, you can see here, we are having many asymptomatic cases in our context. You can see here about 80% of the confirmed cases are asymptomatic. Only 2 to 10% they have need admission to intensive center unit, but sometimes we have some shortage on the medical facilities. So because also some are exceeded now, because we are having a lot of cases. This is one of our main limitation we are having now. You can see also for the healthcare workers affected in the region. For now, we have more than 2,000 healthcare workers affected. Mostly we have, in terms of ratio, in Niger, in Guinea-Bissau, and also in Sierra Leone, unfortunately, some of them have died. WAHO has been asked to develop a guideline to ensure the free movement of the population because of the opening borders due to some economic reason. We cannot lock down every time. So our head of state asked us to work on that, and this has been proposed to the technical committee and the ministerial committee. It has been validated. So now in some countries, if you arrive there, they will immediately quarantine you. The proposition is if you have been tested before your travel and you don't have any symptom or fever, you can travel, and there is no need to quarantine in the country of destination. This need now to be approved by the head of states during the next meeting. For our challenges in the region, you can see here in terms of testing, we may have some challenges in some countries as a lack of testing capacity in some areas, like in Niger, in Mali, in very remote areas where we may have some insecurity issues. We have able also to identify the gene expert machine available in the region, but now our main problem is we cannot have available cartridge to run them. So this is a problem now we are facing. Another challenge is the transportation of samples from the remote areas to the capital city, where we have some laboratories in some countries. This remains one of our challenge. We have also some lack in community engagement in many countries, and also a lack of inadequate human workforce and training. So in case management, many of our medical facilities are exceeded, and in some countries they have a lack of material in IPC and also in the intensive care unit. So in terms of IPC, in some countries we may have some difficulty to access to IPC material and equipment, and also we need more training to be sure to ensure we have adequate human resources to do that work. One of our main problems is also the weak compliance with the non-pharmaceutical measures. As you see, in many countries in West Africa, people are not aware on all the public health measures, such as measure barrier, like wearing masks and all those things. This is a problem for us. So now we are working on it to fix it. So we need, I think, a very strong communication strategy. In this regard, we are now having some questions. How can we expand the testing strategy without exceeding the treatment and care capacity? Because as I said before, we have already in some countries, the treatment capacity and the care capacity are now full, and people are continuing to test people. So this might be a problem. So we need to continue to test more and also to increase the facility where we can isolate and treat the people. How we can also manage the asymptomatic cases, because as you know, some of them are at the beginning of the epidemic. Some countries decided to make them in some hotel or some non-medical facilities, but by the way, there are a lot of people, and this strategy are not sustainable now. So now this is one of our challenge we are facing. For economic reasons also, we need to open our borders, but we need also to prevent the spread of the epidemic at the same time. It is a balance we need to do. And also we need to answer the continuity of the services despite COVID-19, because what we have seen in many of our regions, in our country, people are not going to the hospital because of COVID-19, and this may cause more deaths than COVID-19. In my final remark, I can say we have been better prepared than during Ebola crisis. As you say, we have established many mechanisms and many networks for sharing documents, and also the biobank and all those things we didn't have during Ebola crisis, but the pandemic still going up. So now we need to improve our response strategies. We need also to protect our most vulnerable population, but all those actions need to be taken according to current scientific knowledge, because we are knowing every day more on the virus, and also more on how to treat, how to isolate this pandemic. We need also a strong risk communication strategy, because we need community engagement if we want to fight against this pandemic. These are our few experiences we had in this epidemic, and we would like to share with you. Thank you very much, Mr. Chair.
Oh, merci, Dr. So, for that wonderful presentation. And thank you for the great work you're doing with WAHO. And when it comes to COVID-19 response, I can say I'm happy to be a Nigerian, and I'm happy to come from West Africa, because it is clear that though we still have a lot of challenges when it comes to the health sector in Nigeria and West Africa, with COVID-19, there's a clear strategy. And the clear strategy is shown in the results. We have a few number of cases, and the death rate in West Africa is relatively low compared to other regions of the world. And this is thanks to the good work people like Dr. So and other WAHO members are doing in the region. Your strategy is clear. I love the way you are coordinating the region, especially when it comes to capacity building and trying to expand the laboratories. I've been part of some of your meetings, and I can see that the coordinations and strategies is very clear. So thank you for the good work of Dr. Swan. Keep on the good work. Yeah, we'll go straight to the next speaker. Before we go straight to the next speaker, let me say again, if you have any question, you can just type it on the chat. We are going to read it at the end of the presentations. We have about 10 to 15 minutes for question and answer. So I'll go straight to the next speaker, and the next speaker is Dr. Nahid Badelia. Dr. Nahid Badelia is an infectious disease physician and the medical director of Special Pathogens Unit at Boston University School of Medicine. She oversees a medical response program for Boston University's maximum containment biosafety level 4 program at National Emerging Infectious Disease Laboratories. She serves on national and interagency groups focused on medical countermeasures. The intersection between public health preparedness, research, and clinical care for emerging infectious diseases. During the West Africa Ebola epidemic, she served as a clinician in several Ebola treatment units, working with World Health Organization and partners in health. Let me say thank you, Dr. Nahid, for the great work you did during the Ebola epidemic in West Africa and Central Africa. You've worked and you've risked a lot working with different countries, Uganda and different other countries during the Ebola epidemic. Thank you for the great work you're doing in Africa. And I'll hand over the floor for you to speak for between 10 to 15 minutes. Dr. Nahid, you have the floor, please.
Thank you so much. I'm going to try to share my screen here. It is a pleasure for me to join the GET Consortium again. I remember only a year ago, I was in Abuja with you in person, and how the world has changed in this short period of time. What I wanted to do today is just to speak from a medical response and healthcare facility response perspective for COVID-19 and the lessons for global health security and for the global community. But I'm going to do something different. Most of my work, as you've said, is both divided in the United States as well as globally, and particularly in West Africa and in Uganda. But I thought that a focus on United States and since all of our destinies are so intertwined during this pandemic, would serve as an important, reflection on how we've all come together in response to this. So this is, Ambassador Jenkins mentioned the joint external evaluations of the International Health Regulation core capacities, and this was the result of the United States JEE results. And you can sort of see here that for the most part, we did pretty well, but there are definitely areas, including antimicrobial stewardship, the surveillance for priority zoonotic diseases and pathogens, and then real-time reporting that were pointed out as areas of weakness. But I think none of us would have expected our crisis to have expanded to the point that it did, compared to many other countries who had, had many of those resources in place. And so I thought what would be good to sort of talk about is how we designed our global health security response here and in an interface with other countries, and what the benefits and sort of some of the weaknesses that COVID-19 pandemic revealed in our response, which has a community. So after the West Africa Ebola epidemic, the Assistant Secretary for Preparedness and Response here in the United States made a point to make an investment in a tiered system in the healthcare setting where they provided funding and training and resources to create 3 tiers of hospitals that can take care of patients with viral hemorrhagic fevers or infectious diseases of high communicability. So those are frontline facilities, Ebola facilities, and Ebola treatment centers. And there were about 50 to 60 of these Ebola treatment centers across the country that had specialized units, 2 or 3 beds, including our own here at Boston Medical Center. But as our community sort of reflected on this, I think there was always a fear that, you know, the system was great to take care of a patient with a disease that has high mortality, but is not as easy to transmit. The weakness that, you know, all of us worried about, which I think COVID-19 exposed, was the fact that it's much harder when it's a pandemic, a respiratory virus pandemic that can spread very easily and overwhelm healthcare systems. It's a different type of challenge, and some of the work that we did to build that response in the US for Ebola did help. The training, the healthcare worker training and personal protective equipment, the readiness in terms of identifying patients in our emergency rooms, but there were a lot of weaknesses of our current system that was revealed that, you know, that I think are worth looking at. So here's some of the strategies that the U.S. hospitals employed during COVID-19. Most of the hospitals at the very beginning in February, January and February, started running regional, if you may remember, we think our initial cases in community transmission in the U.S. probably started in February, if not end of January. And so hospitals started running these scenarios based on models, national models, and what they expected this disease to do based on the data that we were getting from Italy and from China. And what that allowed the hospitals to do is project the need for staff, for hospital beds, for personal protective equipment, for medications, and they planned the surge in that fashion. And the work that went into that was identifying spaces within healthcare facilities where patients can be taken care of. You know, there were entire units that were converted into intensive care units that were not intensive care units. There were staff that were brought from other parts of the healthcare delivery system to provide care during the surge here in Boston. And for those outside of the US, New York and Massachusetts, the two states here in the Northeast, along with a bunch of other neighboring states, were hit very hard in March and April. And in May, finally, the cases started to come down. At the worst month, our hospital, my hospital, was 70% COVID-19 patients. So some of the lessons that we sort of learned where, you know, you can plan for the surge, but there's certain things that you can't really plan for within the facility itself, which is the needs change, right? We planned for how much personal protective equipment we may need. What we didn't realize is that science was going to change, and then we would find out that there was asymptomatic transmission of this disease, which meant that we needed personal protective equipment, not just for healthcare workers that were taking care of COVID patients, but all healthcare workers, because they might interact with somebody who has COVID and may not realize it. And so if they perform high-risk procedures, you know, such as intubating somebody or you know, giving them nebulizers for their lungs, that they're going to be at risk if we don't test them. And the other things that we couldn't plan for is that, you know, when there's a fire in one place, you can sort of plan to address that fire. But if the fire is everywhere, if the pandemic is everywhere, entire supply chains are affected. And so we had a really hard time managing and securing. To this date, I don't think, you know, most hospitals in the United States could say that they have managed and have enough to last them throughout the planned entire fall. If there's a large second peak, I don't think most places here have that. The kind of other shortages that we saw were, you know, medications for patients who are mechanically ventilated, sedatives. We didn't, you know, well, we realized that there were shortages across the country because all those medications are being used in New York or elsewhere, aside from their need in Massachusetts. So the need elsewhere is affecting the global supply in every single space. And the global capacity for surge is not just facility capacity for surge, but global capacity for surge, for manufacturing, for distribution, still seems not to be as strong as it can be. The other things that we did was change, you know, infection control procedures within all the facilities to reduce chances of transmission, reduce visitors, the number of staff that see patients, the amount of time they go in. We expanded testing, and Dr. So talked about the availability of kits and testing. One of the difficulties that we had were very beginning of this, you know, we waited for the CDC kit rather than WHO testing kits. And there was a lot of question as the testing move from laboratories at the state to within our facilities to how to evaluate the efficacy of the testing, how accurate it was while providing care. Because sometimes we would see patients that very much look like COVID-19, but their PCR tests would come back negative. And so as clinicians, as hospitals, we had to make on-the-go guidelines about, you know, how do we retest patients? What type of sample should it be? What kind of test should it be? And then the last part of this is evaluating and developing guidance for crisis standard of care. Thankfully, we here in Massachusetts did not have to get to a point where we had to. Crisis standard of care refers to this idea that if you get to a point where you don't have enough resources, then you know, for all patients who present to your door, how do you make a decision about which patients get those resources? So as Dr. Johnson just talked about, I'd served in West Africa, and as a clinician who had to make these types of decisions at bedside in Sierra Leone, these are heartbreaking decisions. And one of the good things that I think many states ended up doing here in the US is they made those decisions not at the individual or hospital level, but they made it at the district level or state level, which took the pressure off. They put guidances into place about what those should be. Part of the challenges that I think we faced is what is inherent in general. So this image is, this is taken with permission from the patients. This is from Sierra Leone in 2014 from my own Ebola treatment unit. But we published recently about the lessons of just the unique challenges. It's not just a pandemic with any pathogen, pandemics with emerging pathogens that we're learning about. The big part of this is the evolving scientific knowledge and the ability to sort of adapt public health policy and medical response to evolving scientific knowledge remains a big challenge. The other is, generally for emerging pathogens, you don't yet have therapeutics or diagnostics. So this is everybody in the world starts off at the same place. But then even as facile diagnostics and therapeutics develop, it becomes a question of distributive justice. How do we get all those diagnostic and therapeutics to all the parts of the world that need it? Because an outbreak everywhere is an outbreak anywhere is an outbreak everywhere. The other is the same lessons that we learned from Ebola in West Africa and then in DRC and Uganda are being applied for care everywhere these days, which is balancing research and response activities. How do we evaluate medical countermeasures, new therapies, in a scientific manner that can tell us about their true efficacy, while we're also responding and putting all those resources into taking care of patients. And then the ethics of conducting research and then making public health policy with evolving data. And so just diving in a bit more about the evolving science and outbreak response, the kind of factors that this applies to are diagnostic assays, figuring out their accuracy and their use within the public health system and the medical system. Where do we use a quick point of care test? Where do we use a PCR test? What do we do with serology testing that we don't yet know, whether or not it's accurate and may have a high false positive rate in an environment where the prevalence may not be as high? And what kind of knowledge does that even give us? And then translating that has been very difficult. So this is the antibody test that I'm referring to. And then there is the work that I think we did do well, which was that we took innovative methods to adapt to shortages and roadblocks. So one example is personal protective equipment. Significant amount of innovation went into, since we're running out of personal protective equipment, on how to safely disinfect personal protective equipment, such as N95s. Here you're seeing a UV light that we set up in our hospital for a setup similar to University of Nebraska Medical Center setup to help disinfect N95s to use again. And those kind of innovations were very important to try to meet gaps that we were finding. Other things that we saw where companies came out and 3D printed face shields in a cheap manner that were easy for our healthcare workers to use. The factors that still remain a challenge, and I'm weary of the time, and I want to make sure Dr. Lamort gets his allotted time, was there's a lot of public health. There's a lot of public health denialism still with COVID-19 here in the United States. There's for the most part, most folks There's a Pew Research study that shows that about 70% of Americans will wear masks. And at some point, 90% have said it's appropriate to wear a mask, but we have a small minority that is very vocal about the fact that they don't believe that COVID-19 is real. You know, the impact of it is not real. And what we found is that even in a healthcare system as rich as the United States, you can see the impact pandemics can have. This is the number of excess deaths that we saw, basically the result of not just COVID-19 deaths, but a whole fraction above what you would expect at the same time during any year. We saw an increase in those deaths, and that was because of the fact that people were not able to come to care because hospitals are filled in Northeast with COVID-19 patients. And things like vaccinations, you know, CDC's vaccine tracking showed that measles vaccination ordering went down in March. So vaccinations fell behind. And that's a global concern. It's something that WHO has expressed everywhere. So a big part for us, you know, as we face this, we're in a battle with ourselves. It's a self-inflicted wound. As I end this, the big things that I think that aside from the better crisis communication, public health communications in crisis, the things that we need to sort of reflect on from the U.S. response are the universal need for surge capacity, the fact that we need to repatriate or regionalize supply chains and invest in stockpiles. And, you know, after West Africa, there was a conversation about the African CDC and the African Union sort of becoming that potential body that might be able to do that regionally. And I think that's a strategy the U.S. could learn from, the idea that there could be regional stockpiles. Since, you know, we don't have as strong a the national picture is muddied. Every state has their own reality. You know, we now have a outbreak going on in Sunbelt states here in the U.S. And so this regionalization of stockpiles and repatriating supply chains would help that. The other parts are, you know, how important academic, commercial, and public health labs all were in expanding and leveraging testing capacity here in the U.S. And that was true in West Africa. I think Dr. Lamore can talk about the importance of that in Uganda as well. We also discovered here in the US, and this is true of everywhere, the importance of updating data collection systems and reporting systems at all levels of public health. You know, we discovered that all states are reporting deaths differently. With COVID-19, some states are not reporting hospitalizations. There's not lack of uniformity sort of, you know, does not allow us to get a clear picture of where this pandemic is moving. And then the last bit is need for greater public collaboration with the private industry. So I will end there and hand the mic over to Dr. Lamore or Dr. Dutton again.
Yeah, thank you, Dr. Knight, for that wonderful presentation on U.S. response to COVID-19. And now we've had response from U.S. to COVID-19, we've had response from WAHO. I'll move straight to East Africa, where we have someone that will take us through the response to COVID-19 in East Africa. We can have comparison of what is happening in different parts of the world. And the person that will do this is Dr. Mohamed Lamode. Dr. Mohamed is the head of Department of the Prevention, Care and Treatment Program at the Infectious Disease Institute, IDI, Makerere University College of Health Science, Kampala, Uganda. He has a PhD from Trinity College, Dublin, Ireland, and he's going to take us through response to COVID-19 in East Africa. Dr. Mohamed, are you there? You have the floor, please.
Thank you very much. I really want to appreciate the organizers for giving me the opportunity to present. The talk I'm going to give is really going to highlight our experience in East Africa, but I really wanted to focus especially on Uganda, which is where I work, as well as give an idea of a model that other organizations or non-state actors can play during pandemics. So this is the popular strategy that we see. This is from Resolve to Save Lives. You want to test widely, you want to isolate all infected people, you want to find everybody who's been in contact with them and then quarantine them. And by doing that, we box in the virus and then prevent further spread. The East Africa picture looks somewhat like this. This is data from the East African Communities Dashboard. And you can see that for some countries, the larger population countries like Ethiopia and Kenya have more cases. The small countries like Seychelles have very few cases. But then you have case of Uganda, and in Uganda you have about 1,000 cases and no deaths. And Uganda's population is just a little lower than Kenya and Sudan. We really want to understand this phenomenon. Ambassador Jenkins talked earlier about the global health security agenda. Now, Uganda was one of the first countries actually worldwide to sign up to the initiative, and was actually even in the pilot prior to GHSA, one of the few countries that opened up its systems for evaluation. And since then, it has really been in the forefront of advancing GHSA goals in Africa, including holding the first high-level ministers meeting that was held in Africa, and I think that was in 2017. Since that period, Uganda has had reason to really value its investments in GHSA. Uganda tends to have an ongoing stream of outbreaks, and I've just given a snapshot for 2 years that shows the kinds of viral hemorrhagic fevers that are seen, other diseases like anthrax, and highly pathogenic avian influenza. So we always talk about health security as a responsibility of government. But when you go to the field during outbreaks, you tend to see a lot of volunteers. And so you ask, can one person really make a difference? Yes, a person can make a difference. You can volunteer time and contribute to outbreak response. But what volunteers would tell you that it's often very hard, and the capacity you try to build may not be sustained. In IDI, that's the institution where I work with, we now think of the approach of institutions. So rather than having governments leading volunteers coming in, how can we repurpose some of the existing institutions that we have and make them immediate supports for government? So this is the institute that I work in Uganda. It's wholly owned by the university, so it's 100% locally owned organization. It has been developed over the years with a focus of HIV care. So this is really leveraging some of the PEPFAR investments. It has programs including research, clinical care, outreach, laboratory. But last year, it launched a full-blown global health security program. So a strategic decision was made to establish one whole section of the organization to be devoted to issues around health security. And this also was derived from what we've known from the Ebola outbreak in Sierra Leone, where we realized that health systems were weak and there was lack of preparedness. So how do we use organizations, especially academic organizations, to support government in ensuring that countries are more prepared? So if you looked at the components of the program that we implement in the Institute, we have a laboratory and biosafety, biosecurity emphasis. This is one of the strategic areas. We have an epidemiology area, and we have an infection prevention and control, case management, as well as medical countermeasures area. So 3 separate areas. And with the funding that we received from CDC, we helped to harmonize the country's biosafety, biosecurity curriculum, and also ensure that we had a pool of trainers, a national pool of trainers that could deliver those trainings, as well as auditors that could go to laboratories, for example, at different times of the year to assess, to see compliance with relevant biosafety standards. Now, since COVID, we've had an unusual series of contributions to the government's response. With one of the funding streams that we received, we were able to contribute in terms of legal advice for development of some of the statutory instruments that were used for the government's efforts to control COVID. And so I bring this up because, biosafety, biosecurity, there is also that component of ensuring that countries have appropriate legal systems. But in this case, we needed laws to ensure that the Minister of Health could legally impose measures to consider COVID as a notifiable disease, but also take some drastic, I would say, steps to control the importation of COVID-19 into Uganda, either through travel from the airports or through land borders. This tool has also been used to legalize rapidly changing public health and social distancing measures that have been announced by the president in Uganda, and to ensure that everything is enshrined in law. Now, as an institution, one of the things we would have over a period of years of preparedness funding is skilled staff. And once the outbreak, actually even prior to the first case being detected in Uganda, we started deploying those personnel to the Ministry of Health. We have staff supporting the situation room for 24-hour coverage. We have staff that have been deployed to be the deputy leads for border health or the lead for epidemiologists at points of entry. We have staff that had been based at the national laboratories doing antimicrobial resistance work, whose roles were simply repurposed for COVID-19 testing. In addition, the Institute was able to place staff. This is really subcommittee or committee representation of our national task force to contribute in different pillars and support the government's response. So this is putting people that can actually hit the ground running, because these are staff that have been involved in preparedness training in the past. Now, in terms of laboratory, obviously each country has to outline the plan it has for laboratories, but you also need to ensure that you can spread out that training to all the laboratory staff that you have in country. And building on some of the networks and investments in biosafety, biosecurity training, we're able to quickly bring together 131 laboratory trainers, and each trainer would go on to support one of Uganda's districts. So Uganda has a central government as well as 135 districts. And so we'd place one person in each district in the country as a trainer, and that person is also responsible for cascading that training down. And the other thing that was done was to look at the existing partners of government as well. So PEPFAR partners supporting HIV programs were trained, and then they also helped to scale up that training to other laboratory staff across the country. Now, Uganda adopted what I will call a containment strategy for the country. And what it did was really restrict travel through the airports, restrict travel through the land borders. Essentially, it closed all the land borders, but allowed critical services and cargo to continue passing. So you'd end up with truck drivers driving in from Tanzania, driving in from South Sudan, driving in from the Democratic Republic of the Congo, driving in from Kenya, and all the countries around Uganda had a higher prevalence of COVID-19. And so the approach the government used was to ensure that testing capabilities were put at all the critical border crossings, and that people will actually get tested at the borders, and when their results come through, then cargo is allowed to come in. Our institute helped in actually doing an assessment of the 53 points of entry in the country that were gazetted, and also helping those points of entry establish the capacity to collect samples for COVID-19 and send these down to the National Reference Laboratory. And subsequently, working with the government, we're also able to put up some of the mobile labs close to the borders. One of those uses gene expert testing, but the other two are PCR-based, are standard PCR-based assays. And the whole point also is to ensure that when people are coming in, you can reduce the turnaround time of results for COVID-19 testing. Now, when it comes to surveillance, the Institute was able to work with the government of Uganda and rapidly deploy teams. And these teams went to 53 districts and helped to set up the COVID-19 response teams there. And then other partners also contributed to ensure that there was full coverage of the country. I believe Chai, for example, had about 70 districts that were covered. I think this highlights the partnership approach that Uganda continues to use for GHSA, where it involves a wide range of partners and really has open meetings where the needs are clear. And then whoever can move fastest is given the permission to perform some of these tasks. Another interesting thing that we do are called population movement risk assessments, and we started doing this for Ebola. Essentially, you try to find out that if somebody is crossing the border, what is the person's preferred destination on your side of the border, and where is the person's point of origin on the other side of the border. So this is a process known as PopCab, and what it helps you do is to know that if people manage to cross the border, what, for example, health facilities are they likely to visit? What are their points of interest that they come into your country for? What transportation systems do they use? And then you use the limited resources you have to prioritize locations for your interventions for health security. And this could be risk communication or surveillance or infection prevention and control strategies. Another thing we're doing is to ensure that if, particularly now at districts that are close to the borders, right? So these are the border districts. We categorize them as the highest risk districts. And then we ensure that you can get information about COVID from the district, from the health facility, but also from the villages. Each village will have 2 village health team members. These are community health workers. And the intention is to ensure that everybody down to the village level responsible for surveillance is aware of what COVID-19 looks like, and they know how to report electronically. Just using a regular phone and sending an SMS is enough to trigger an alert and investigations. So for a population of about 4 to 5 million, you could have nearly 3,000 village health team people that are trained to support surveillance for COVID. Uganda is rolling out, I think, one of the most ambitious infection prevention control mentorship programs. We sort of knew that for our health systems, infection prevention and control was weak. And we also knew that those weaknesses were widespread. Now, this is a model that was used in just one district in Uganda. And here you send mentors that are derived from the health facilities in the district. So you get about 10 mentors from one district, and then you train them on infection prevention and control, mainly routine IPC, but you also put some elements that are relevant to COVID-19. And then you send these back, and then they go to their own facility, and once a week, they provide support for infection prevention and control improvements. And then they also are allocated 2 to 3 other facilities. And what you give is a transport allowance for them to move to those other facilities. And over a period of 4 weeks for each facility, we found that even if you don't put any other resource, you're able to get improvements in routine IPC, from ensuring that a facility has a functional screening station, for ensuring that facilities have prioritized cleaning and disinfection, and they know how to use a triple bucket system. You're able to bring out quite a bit from the system, even without additional investment. And IPC scores tend to improve by about 20 to 30% over a period of 4 weeks of mentorship. Now, why I say this is particularly impressive in Uganda is that all the HIV partners that support HIV programming have agreed to support these mentorships in their regions. And so right now we have virtually all parts of the country rolling out this program. For some places, they are currently on the week 4 of the mentorship. Other areas are in the first and second weeks of their mentorship. The other thing you need to think about for infection prevention and control is places where people that are high-risk contacts are supported. So quarantine facilities, but also along the points of entry, we've seen a few infections, including from responders, happening at the points of entry. And this is partly because, as I said, you have so many people trying to come in and getting tested, and some of them have COVID-19. In fact, truck drivers coming in from our borders are the biggest contributors for our COVID-19 caseload in Uganda. Now, when you want to do risk communication, you also want to prioritize who you target. Now, right from the beginning, we knew there were going to be a lot of myths about COVID-19. And so we set up WhatsApp groups within the Institute, but we also got permission from the Ministry of Health to set up a WhatsApp group for the regional referral hospitals. These are the government hospitals that now serve as COVID treatment units. And we created a forum for people to bring in information that they've heard about COVID and really just ask, is this true? And then somebody on the platform will help to respond. Now, in the first 2 months of the outbreak, there were a lot of myths that were coming out, but subsequently, people started knowing what verifiable sources of information were, and they were able to even police themselves and say, no, 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 don't send that, check the WHO website or check the Ministry of Health website. Now, healthcare worker infections remain a challenge everywhere. We had about 26 healthcare worker infections in Uganda, and active monitoring of healthcare workers in COVID treatment units is going on with screening logs, self-monitoring tools, and also risk assessments if healthcare workers get exposed. And this is an example of a log that is used in Fort Portal, where Dr. Nahid has also been active and doing some work. And Fort Portal is the location where we have this facility. This is called the JMedic facilities, Joint Mobile Emerging Diseases Intervention Clinical Capability. And this is really a center that was set up to help research and drug development for Ebola and other filoviruses. Now, it's a complex partnership that requires a lot of stakeholder management. But I bring this up because I think these are the types of investments that countries need, where you have at least one center of excellence for the management of especially dangerous pathogens, but also as a location where you can bring in investigational or research drugs to ensure that your population can be among the first to receive new treatments, but also contribute to the development of new treatments, because when you contribute to the development of new treatments, you're also more likely to be one of the first to benefit from those treatments when those treatments become available. And the kinds of resources you would find here are clinical teams, an isolation laboratory, research ward. As you can see, everything is all nice and shiny. And the Ministry of Health 2 weeks ago decided that this would be the location where COVID-19 treatment, COVID-19 patients in Fort Portal Hospital would be managed. So really, this is the vision of the Institute, a healthy Africa free from the burden of infectious diseases. What I bring this out is that, you know, organizations can change. We can change our strategies when we see threats that are emerging in our countries, and we can align ourselves alongside government and provide support during outbreaks. And it should not always be seen as a role of government and maybe a few international NGOs. What we want to see is local institutions that can come alongside government, generate resources and address any gaps that might be seen during the early phases of an epidemic. So I'd like to thank you all and thank the funders and partners that support our work.
Well, thank you, Dr. Mohammed. That was a great presentation. Great, very great presentation. Something I heard, and I'm not sure I clearly, you said Uganda does not have a single death as a result of COVID-19. Is that true?
Yes, we have no deaths from COVID-19.
That is great. Please, is it that you guys are not taking proper records, or you're doing something that the world is not doing? Please, can you just tell us for 2 minutes? Why are you different from every other country on the surface of the earth?
Exactly. I think Uganda, as I said, is used to Ebola and other really life-threatening outbreaks. We panicked earlier than most countries. We shut down the airport and closed our borders earlier than most African countries. We also are not like, for example, Nigeria, where there is a huge volume of international traffic. And so we had very few confirmed cases in country by the time we shut down our borders. And then we went quickly into lockdown mode, which went on for more than 6-7 weeks. And the idea was to ensure that all those cases that had made it through to the country were identified. So up to 13,000 people were traced that had recently traveled into the country. And it initially was from specific countries, but eventually was from all countries. And there were testing centers put for all recent travelers to come in themselves and test and find out if they had COVID-19. We've also used one of the more aggressive testing strategies in Africa. So as I mentioned, we have very few cases confirmed, but we've actually done more testing than Kenya. And then by ensuring that we sealed the borders and only allowed critical people to cross, and then ensure that those people crossing were tested, we've been able to narrow down the areas where COVID is present to the truck driving routes across the country. And then we continue doing surveillance in those locations to ensure we keep the numbers down. The health system in Uganda, maybe in terms of the hospitals, are actually weaker than other African countries. We don't necessarily have a very strong hospital system. And so a decision was made to fight the disease through surveillance and at the borders rather than through the healthcare system.
Wow, great. Thank you for that. At least we have a developing country in Africa that is leading in disease surveillance, and other countries in different parts of the world can learn from what Uganda is doing. And that is one of the aim of this webinar. That experts can come together to learn from each other. And it's not just learning from each other. The plan of GET is, from this webinar series, we'll develop policy documents and policy briefs that hopefully will be useful for policymakers in different parts of the world to take decisions, not just for COVID, but for any other health emergency we might have in the future. So thank you, our presenters. I've learned so much from this presentation, and almost 1 hour, 30 minutes have gone like 5 minutes. I'm going to take about just two or three questions because we are behind on time, and GET doesn't we like keeping to time. That's who we are in GET. So I'm going to take 2 questions, then we have the remaining questions, and we'll share the answers. We share the questions with our speakers, and hopefully they will respond to them, and we'll share their response with the audience. First question. Okay, first question, I think the first question goes to Dr. So, and maybe Dr. Mohamed too. Says, sir, what treatment do you offer for, I guess, for COVID-19? So, Dr. So, Dr. Mohamed, can you just respond briefly to that?
So I can say briefly for Uganda, most of of the people we have in hospital are actually not sick. They're like healthy truck drivers that we found COVID when we did testing. So most of them are asymptomatic and they're just being monitored. There were very few patients that had comorbidities like diabetes that had a few more symptoms. Uganda signed up to do some of the investigational drugs like chloroquine and lopinavir ritonavir. But over time, we've seen that the usefulness of those drugs is not effective, and so those have been dropped. And right now, dexamethasone is under consideration for severe cases based on data from the UK.
Okay, great. Dr. So, please.
Yes, thank you very much for your question. I think in the region, as a colleague from Uganda said, we don't have a specific treatment. We are just following what has been approved and recommended by the health authorities. And if, for example, in some countries, they are using hydroxychloroquine for the moderate cases, and also they are also trying to stabilize all the comorbidities. And recently, they are start using also the dexamethasone for the severe cases. So for the asymptomatic, as our colleague said, in the region, they are just staying in some facilities or at home. They are just monitoring them without any specific treatment. Thank you.
Okay, great. Thank you. Yeah. Next question from, I think, Professor Morenike. Beautiful presentation from WAHO, truly enlightening. A critical lesson we learned from Ebola is a role and place for community engagement in making grassroots response effective. The COVID response seems not to have prioritized this. What is the community engagement strategy for the region? I guess that's for West Africa. Dr. So.
Yes, thank you. Thank you for your question. I think the problem we are having in the region, as I said, is the weak awareness of compliance on the public health measures. It is due to some lack of communication or lack of risk communication, community engagement. This for example, avoiding going to the hospital. This may lead to some community deaths, which can be missed. And also we can have some delay on the notification of the case at the hospital, and they are coming too late. So it's why people are having severe cases and deaths at the hospital. And also this can contribute to spread the epidemic in the community. So for now, the strategy people are doing in the region, they are not harmonized strategy for all the 15 countries in the region. So WAHO is promoting some socio-anthropological studies to understand what are the determinant of this community engagement issues. And also they are promoting the increase of social media using, because they are doing a lot of messages there. Also familiar or familiar strategies of sensitization, like videos, posters in the community, and also doing some campaign. You can see I'm not a risk communication specialist, but what I can see from my colleagues, they are doing those things. I can say these few words. So if I revert to them with a question, maybe we can share with our colleagues from GET all the comprehensive strategy they are doing in the region. Thank you.
Oh, great, great. We are happy to have that we'll share with our audience. I think that's the two questions we can take. We are from a few minutes. We've used our time, overused our time. We'll harvest the remaining questions and we'll get back to, we'll send it to the presenters, and hopefully they'll give us a response and we'll send it back to the participants. So we are coming to the end of the program, and let me give 1 minute to Bonnie and Nai to say something. Bonnie, you have anything last final word? 1 minute.
Oh, not really. Just want to thank you for inviting me to speak and to be a part of this. I mean, I've learned so much, and I had no idea there were no deaths in Uganda. I think that's amazing. Just to say what's really happening out there. So I think it's very just really great to hear from all the amazing panelists and what they're all doing to in this effort to combat COVID-19 and highlighting the role that they're all playing. So just thank you very much for my being a part of this.
Thank you, great. Yeah, Naid, 1 minute.
Yeah, Same. Thank you so much for having me. It's a pleasure to be back with GET. And one thing for me, and Dr. Muhammad will say this, I think that my work in Uganda or in West Africa has always guided the work that I do here in the U.S. and vice versa. And just the lessons that we've learned, in all the outbreaks, as working together as a community, global community in East Africa and West Africa, are so applicable for the rest of the world. And to me, that is the biggest lesson right now in the United States, how, for example, we can learn from, as one of the people who asked the question said, it's all about community engagement. It's about, and so the kind of community engagement that we did in West Africa and in DRC to bring people over to care, to win their trust, that is the type of work that we need here in the United States. Those lessons can actually be translated back. It's not a one-way street, and that's the important part.
Yeah, great. Yeah, so we've come to the end of today's webinar program. Let me thank our presenters for the wonderful presentations they've made today. I've learned so much, and I believe it's not just me. Everybody on this platform today have learned so much. We've had presentations from Bonnie that she took us through the global health security agenda. We have presentation from WAHO. Dr. So took us through the WAHO response in West Africa. We had the response from US, from NIAID, and finally the response from East Africa from Dr. Mohamed. So we've listened to response from different parts of the world, from developed and developing countries, and I'm sure a lot of experts listening to us have learned one thing or the other from what is happening either in the developed or developing countries. This is one of the things GET is doing, to create a platform for researchers and experts from different parts of the world to share ideas and to learn from each other. So thank you very much, our presenters. On behalf of GET, thank you for the wonderful presentation today. And to our participants that have stayed with us for 1 hour, 30 minutes listening to what our presenters have to say, I want to say thank you for staying with us, for attending these webinars. These are webinar series, and particularly the one for today. If we don't have participants, then the webinar will not be interesting. So we thank you for attending. I hope we've learned so much, and what we've learned, we'll take it back to our communities and our cities and our workplaces, and we'll use it to influence decisions and strategies. That is the aim of this. And on behalf of GET Consortium, I say thank you to everybody, and I hope we can continue to work together. We are working with WAHO, NIAID. I think we should continue where we stopped. Bonnie is part of the team, and I think we should learn so much from Uganda. So thank you, and have a great evening from Nigeria. Bye-bye to everybody. We'll see you next time. Bye.
Thank you. Bye.
Yeah.
Thank you very much.
Yeah, bye.